Bismillahirrahmanirrahim. Dear colleagues, ladies and gentlemen, once again we are here on Sunday evening, and this time we have ERCP cannulation technique. We have with us Mohammed Khalid. He doesn't need an introduction. He's the son of the soil, working at the moment in Florida as Director Advanced Fellowship, Advanced Endoscopy Center in the Florida Hospital. I've been to Florida Hospital. It's a seven-star hotel. It looks more like a hotel rather than a hospital, and providing excellent service over there. Um, Khalid is a champion in endoscopic ultrasound and ERCP. He has been a teacher, mentor in endoscopic ultrasound. We are very thankful to Khalid for sparing his time on Sunday evening, which is basically a family time. And he's going to talk to us on cannulation techniques and ERCP. I'm sure you all understand that ERCP starts with the cannulation, ends with the cannulation. Once you have done the cannulation, rest of the things comes afterwards. And to teach us the tricks in achieving cannulation in more than 95% cases, Carl is going to guide us on various methods. Last time we had a discussion on the anatomy of the ampulla, and it uh, and the anatomy of the ampulla was emphasized very clearly, because without the clear understanding of the anatomy of the ampulla, I know the understanding about the cannulation will be difficult. And Bakar had done a great job in teaching you and making you understand the anatomy of the ampulla. And from that point onwards, Khalid is going to take over on the cannulation technique in ERCP. Khalid, all yours.
Thank you so much, Yasbay. Thank you for the kind introduction, as always. I always have a little bit interest in historical perspective, be it EUS, ERCP. So first, ERCP was really performed in 1968, and it was Dr. William McCune who performed first ERCP. Then in 1972, my mentor, Dr. Peter Cotton, he published a report of 60 cases of ERCP. That was mainly diagnostic and first endoscopic sphincterotomy. It was simultaneously performed, one in Japan and one in Germany at the same time, 1974. Then oral cholecystoscopy in 1977, and then successful stent placement in 1980. And then metal stents came, and that was placed in 1989. And the rest, you can, you know, that's the history and where we stand on that part right now. So one thing I really want to stress is we used to do a lot of diagnostic ERCPs maybe 10, 15 years ago, but this age and era, the indication for ERCP is really only therapeutic indication, very minimal diagnostic, but mainly therapeutic. And before we go for ERCP, we need to know the right indication, and where we run into trouble, where patients run into problems with complications, is usually the scenario where the indication is not very obvious. So the major indications we know is an cholangitis, obstructive jaundice, stones, strictures, tumors, bile leaks, other post-op complications, and treatment of any sort of pancreatitis. So just, we have so many diagnostic modalities nowadays. We have cross-sectional imaging, we have endoscopic ultrasound, so ERCP should almost always exclusively be therapeutic. And you heard on anatomy of ampulla previously. Just to remind a little bit about that. We know major papilla, it's on the medial wall of second part of the duodenum, mainly drains bile duct and ventral pancreatic duct. Minor papilla is proximal to the major papilla, and usually towards a little bit to the lateral side, and it becomes more important in cases of pancreas divisum, because in that case, this would be a major drainage pathway for the pancreas. So this is a picture of anatomy. the one of the reasons I put that on is because I want you to see that how the sphincter is made. There is a separate fibers for common bile duct and separate for the pancreatic sphincter. So if we are doing obviously there is a common portion of that too. Biliary sphincterotomy, I always say, unless there is a strong reason to not do a complete sphincterotomy and then do a balloon dilation, that those are totally different topics, but do a full sphincterotomy. And after you do a full sphincterotomy of the common bile duct, the risk of stenosis is really low. And if you're doing a pancreatic therapy, then also you have to cut the sphincter. There is some chance, 10% risk of restenosis of the pancreatic sphincter. But if it's somebody requires a pancreatic therapy, then they need a sphincterotomy, pancreatic sphincterotomy as well. Just a few things on diameter of the pancreatic duct and bile duct. Bile duct diameter is 6 millimeter or less. And in case of pancreas, we always talk about 3-to-1 formula, which is 3 millimeter in the head, 2 millimeter in the neck, and 1 millimeter in the body and tail of the pancreas. Sometimes there could be a functional dilation of the common bile duct without any obvious obstructive lesion. It can happen in post-cholecystectomy because then bile duct take a portion of a reservoir function. But usually in case of post-cholecystectomy dilation, the change in diameter should not be more than 2 millimeter. If somebody had a 6 millimeter bile duct before, usually it should not go above 8 millimeter. If it goes above that, then consider some secondary causes as well. It can happen, you never say no, but then do think about secondary causes. We come across a lot here in Western countries due to use of narcotics, the duct gets dilated. There could be some anatomical variations, and also in elderly patients, and especially due to a duodenal diverticulum, and the diameter of the duct can increase. So now I would switch a little bit gear to about the cannulation. I say that usually say that you have to become a papillologist. You have to study the papilla. I cannot stress enough that don't touch the papilla until you know that what the anatomy looks like. You have to have this roadmap in your head. After looking at the papilla, obviously it's important to take a look at the papilla, but it's also important, of same degree of importance, to look how the upper part of the papilla looks like. And I'll show you a picture in a few in next slide. And then after you study the papilla and you have got into the good position, that's only time you should touch the papilla with the wire or cannula or sphincterotome, whatever accessories you have to use. And it's always slow, calculated movements at the ampulla. That increases your chances of selective cannulation. It's some of us say to become a RCPist, you have to unlearn the colonoscopy, really. You can't do the same sort of movements. And I usually call it, don't do purposeless dancing movements. That's not gonna help you. And just, you have to move the shoulders, may have to move the arm, may have to move the wrist, but it's a very, very calculated movement. So you can't just swing from right to left or left to right and hoping that you would find your way in. You might get lucky one, but not always. And also remember that no one technique fits all situation. You have to take a look at the papilla. Some are flat papillas, other are floppy papillas. I'll show you the pictures of some of those. And based on the anatomy of the papilla, you have to use that particular technique. Some of us use a wire-guided technique, others use a gentle injection. It used to be that you inject and then put the wire in. Now, most of us are doing a wire-guided technique. But whatever you do, try not to distort the papilla and try to keep it as friendly as possible. Because if you make papilla angry, that's never going to help you. So here are some examples of papilla. If you look here, this is the lateral projection. So three most common. One is the simpler one in, if you can recognize that, is that the septum really comes all the way to the opening. So there is a separate biliary orifice, separate pancreatic orifice. And then there are two other major forms where the septum, here you can see a long common channel. Septum is really, really high up there. So you really have, when you go into that papilla, go into the lumen of the papilla, and if you happen to inject, you would see you fill both of those ducts, and that gives you an idea that you need to go upwards to get into the bile duct. And then there is another third form of papilla where the septum really doesn't come all the way to the orifice. It just is a little above that, a few millimeter above that, but it's a common orifice. So these are the three major types. And if you look at the papilla itself, here it looks very simple, straightforward. Here you can see there are two orifices. One is up here, one right here. This is a kind of a tricky papilla. And what I always do is, always teach is, when you get to the papilla, after you get into the position, freeze the image. It's obviously important to know where the orifice itself is. But to me, even more important to really get a selective cannulation is, and to get a less traumatic, least possible traumatic cannulation is, look at the what's above the papilla, where it's going into the wall. Here you can see this is an orifice. That here, if you look at the papilla, it kind of takes a curve right here. These are the curves, those folds. I give an example of this in a way. Somebody might have previously heard that this example too. When you are in a cecum, you look at the appendiceal orifice, you always see that concave orifice. And if you don't know really where the IC valve is, or you don't see that very clearly, you are in such a position, what you do is you draw a line straight from the center of that concave fold and move big wheel towards you. And when you pull it back, that takes you straight to the IC valve and into the terminal ileum. Same way is here. You have to have this imaginary line after looking at it from the orifice. When you see these folds, these are easy, but when in these cases, when you see these folds, and draw a line from the center of this opening all the way to where this upper fold ends and meets the duodenal wall. Trust me, that is your trajectory of the biliary cannulation. So take your time to study the papilla, and then you use your imagination and use your skill to get into that. So here, and the other thing is what I say, 4 secrets of successful cannulation is, cannot stress that enough, is don't touch the papilla until you are in best position. So the first secret position, second secret position, third secret position, the best position possible you can get in, and then your gentle movements to get into the papilla. And it's not always going to be possible to have a perfect position. So you have to manage that. Sometimes it's a short position, sometimes it's a long position, but don't touch the papilla until you are in best position to touch it. And other axioms of cannulation, if there is a biliary drainage, we can cannulate it, the bile duct. Okay, so there is no hole too small or too tight. If the bile is coming out of it, you can get into that. And it really successful cannulation never depends on pushing harder. It's always axis and angle. And if the papilla is going right or left and you're distorting, pull your cannula back, take a deep breath, talk to your tech for a minute, or talk to your fellow, and then start over. So take your time. And usually whenever you are insinuated, whenever it's becoming a really, really difficult part for you to get into the bile duct, the best way really is to tip up and not really push on the catheter. So that, keep that in mind. The other thing is aligning the sphincter tone with the papilla. Always get under the papilla and then try to cannulate it. Most position which you use is the short position. And but sometimes you have to get into the long position as well. And for minor papilla, really, it's what I call a semi-long position. And if you are into the duodenum, you are in a short position, and the papilla is really right at your forehead, at your hairline, and it's hard to see, then really that means possibly you need to get into the long position to get into the best position to cannulate. In that case, try to not to try to get into long position while you are in there. If you have locked the wheels, unlock all wheels, come back into the stomach and go back in there and stay in long position instead of shortening the scope. And other teaching is the biliary orifice is always between 11 and 1 o'clock position, and pancreatic between 1 and 2. Majority of the time that is true, but not always. There are always a variation, but this is the basic principle that you have to follow. Yes, that is true. So cannulation techniques, tools, if we can afford to have a scope to do a procedure, we should be able to afford to have a cannula, sphincter tone, guide wires, and even a needle knife. I wouldn't be talking much about the needle knife cannulation, and there's a reason for that. When I come to that part, I will mention about that. And also, there's going to be a separate talk really for advanced techniques. So what are the sequences of options, different options of cannulation? Previously, majority of the time, you used to see the catheter, then inject, and then advance the wire, and then different people have adopted different techniques. Some seed the catheter, advance the wire, other use a guide wire tip. Cannulate the orifice with that, then advance catheter over that, and then advance the wire further. So there are different techniques, different ways to do it, and adopt a technique that works for you. Wire guided is maybe less traumatic, less risk of possibly less risk of pancreatitis, but that's not always gonna work for you. If you have this long stricture in a pancreatic cancer or any sort of malignancy, sometimes wire-guided technique, wire doesn't go in the right way until you know what the track of that duct is. So you have to inject in that case to really find your way out, and then guide the wire through that those curves. And that is true with up and over papilla as well. I'll give you example of that too. So here, these are really straight, what I call a straight sharp papillas. And you see there are not much folds over here. So this is a flat papilla. Flat papilla usually are really the most easy one to cannulate. There is still a little bit fold here, but it's this looks like a pretty much straightforward papilla. These are the problematic papillas and reasons for failed cannulation. One of those is called what we call a Sharpie Papilla. I'll show you the example on next slide. It's and then up and over. And also remember that sometimes there's an aberrant relationship between biliary and pancreatic orifice, means they are kind of tilted, twisted with the where you expect the pancreatic orifice to be, that's where the biliary orifice is really, and the pancreatic orifice moves a little bit downwards. And also remember, if you keep going into one duct, but you want to go into the other duct, think of there may be a separate openings, and more you spend time there and keep going into the one duct, it becomes a little difficult to find the separate opening. And also when the septum is coming all the way out, or pretty much all the way out, that also becomes a difficult, because then you can plaster the septum to one or the other side. I'll show you that in a minute too. And then obviously periampullary diverticulum that lead to distortion of the aneurysm. Sometimes periampullary diverticulum is a blessing. You just touch it, you are in. Other times it could be horrific. It takes forever. And then there's an altered anatomy, Bilrod 2, gastric bypass. I have a video of that too. If somebody's interested in seeing that, I'll be happy to show that if we have time. This is the example of Sharpie Papilla. It's a Chinese dog, a lot of skin folds. And when you see that type of papilla, too many folds on that, and it's just like it's really torturing you, because you can see the bile coming out of the orifice, you know where it is, but it's not easy to get into and find your way in there. These type of papillas, obviously we use a sphincterotome most of the time to cannulate, but these, in my personal experience, these type of cannulas, these type of papillas are best cannulated with the straight cannula and without a bow in there. So those usually gently, smoothly kind of straighten those folds out for you, and then you can get in there. Also, you have to many times to really see where exactly the orifice is, you have to move the folds around. So use your, if you want to just make it more apparent, more clear, you want to see it better, use the sphincterotome, use the cannula, whatever you are using instrument to cannulate, move the folds around to have a better view of the papilla. So this is an example of what I call up and over papilla. So you go and take a look at the, you get in there, you're in the best position, and you look at the papilla. If you see this bulge on that, and if you do a little bit suction and that bulge flattens down, immediately think up and over. If that bulge doesn't flatten down, that could be because of a stone there or something else. But if it flattens down when you use a little bit suction, think of up and over and just be prepared for that. So this is an example of up and over papilla. It's a common, you can see here, really that bulge, what I just showed you. And sometimes what happens is the septum is really coming here all the way right there. And you are having a hard time really getting into the biliary orifice. Your wire goes in, it goes like maybe a centimeter, 2 centimeters in, but you can't advance it further because it keeps hitting the roof of the papilla. So the best way in that case is you pull the scope back, big wheel a little bit away from you. What that does, that kind of flattens your way in there. And then you can, if you advance the scope in that angle a little bit, it takes you into the bile duct. So this is another example for my own case. Is you can see a perfect example here. This is the pancreatic orifice there. You see that bulge up there and comes down. And that's an example of up and over papilla. And your path is like really this way. It goes up, comes down, and then have to go up. If you, in this process, when you are advancing your wire, and sometimes wire takes a little loop. When wire takes a loop, that's a good sign. That really, that means the wire is making a loop, and when once it's looping, and that loop almost always takes the lumen, and then don't let that loop go. That's what I'm trying to say. Don't try to straighten the wire to have a tip. In those cases, keep the loop and gently advance, and that would get you in. Other thing is, this is like a basics of doing a ERCP. You have to get to the papilla, obviously. So duodenoscope, even though it's a side view camera, and you have heard me saying all the time, it's just like looking at the ceiling and moving forward. That's how the duodenoscope is. But that doesn't mean it's a blind scope. You still have to see what you are going through. So it's very easy once you I have a different way of even intubating that from the oropharyngeal area. I actually invert the scope upside down and make it like an oral airway, and that takes me and then get over the tongue and go into the esophagus. But here, this is what I really want to stress, that is make the scope passage really easy. Get to the GE junction, and when you get to the stomach, stop there. Please stop there for a couple of seconds. Look at the gastric folds and see where they are. See where they are going. And you see right here, when I'm looking at it, I'm not doing anything. It's not completely blindly I'm doing. I'm following those gastric folds right here. So I'm going to keep following those gastric folds until I get to, I see the pylorus. When I am at the pylorus, obviously you have to let it go, the sunset position. And once you get into the duodenal bulb, please stop again there. And don't try to do this movement that we do with the EGD scope. I know we teach that, and I really don't like that movement. I want it to be done endoscopically and know exactly where really you are going. So here you're gonna see, I'm just gonna follow the lumen, even though big wheel a little bit towards me, I'm looking at that and looking at the folds, keep the big wheel a little bit upwards towards me. And here, when you go into this position, gently advance that. And this is, you see the minor papilla. This is, you are in kind of a semi-long position right now until you advance further, and then you're going to get into the long position. So this is really the best position to work on the minor papilla if you have to. Again, you can see that it's a atraumatic, no major trauma there, and you know exactly where you are going. So just do it under really a visual guidance. And from here, you can, after you get to the major papilla, I get into the position to see it. And now here, I'll stop there. I will take a look at the papilla. Okay, orifice is here. I see this first fold. I see there is a diverticulum, and there's another fold here. So I'm thinking, okay, I gotta get into the bile duct. And also another thing I see is I see a little bit bulge here. Then I'm thinking, okay, it might be an example of up and over papilla. And in the back of my head, now I'm making my plan at the roadmap, and that how I am going to deal with this papilla. So here, my goal is going to be, this is an orifice. Obviously, I got to stay a little bit upwards. I don't know if the septum is coming all the way or how much it's coming outwards. I know this is the orifice, and now I'm looking at the wall. To me, it looks like if I draw, this is a kind of a last fold, and that's where the papilla disappears. So to me, this is the line really of biliary cannulation. So this is what I'm going to keep into my mind when I maneuver with the wire or cannula. I may have to adjust myself while I'm doing that, cannulating that, but at least I have a roadmap in my head now that how I am going to approach this papilla. So I use this tip, what I call wire tip technique. So here, you see that tip went in very nicely, smoothly. Now I'm not pushing it. I am pulling the big wheel towards me and pulling the scope back. And you see that? It's not moving, the wire. And I already was thinking it's probably is up and over papilla. And because the wire is not going in, so I'm injecting a little bit to get an idea about the anatomy there. And then finally I get the idea that it kind of an example of up and over papilla. So I have to adjust my scope, adjust myself a little bit accordingly, and then go from there. Other thing is, there's going to be, this is the same case actually, I'm going to go to the next one. So other cases, who is injects really contrast, and we have a very experienced techs, and I personally train them, all the techs, whoever we hire, and keep them on training for a few months. So I depend on my technicians, but if you have new technician or in a place where really you're not aware of the text much, or your nurses, and in those cases, I would take the injection from them and do it myself, because I know exactly how much I need to inject. It's going to be very little amount at a time, because if I'm not in the right place, I really don't want to do a submucosal injection and then make it even more difficult for me. So now coming to the next one, aberrant orientation. This is the normal. We know that biliary orifice between 11 and 1 o'clock, or 11 to 12, and then pancreatic orifice is between 1 and 2. But as soon as you do a sphincterotomy, pancreatic orifice falls down. It becomes more towards the 5 o'clock position. So if you do a biliary sphincterotomy and then you want to go into the pancreatic orifice, majority of the time you have to look a little bit downwards and not really exactly at 1 to 2 o'clock position. And remember that pancreatic orifice after sphincterotomy always gonna be in this red area. It's never in this yellow area. Yellow area is the cut part. It's not gonna be in there. If you have to look for it, always look it in this red area. In this case, it's a little bit maybe septum coming all the way out. That's why I see a little bit normal tissue here. And but if you have to look for pancreatic orifice, always take a look at that red area. This is an example like where you expect a pancreatic orifice to be. This is not really a perfect example. Usually, sometimes it happens is pancreatic orifice is here and biliary orifice is here, but it's a little bit different anatomy, I would say. And you still see where the biliary orifice is at where you expect a pancreatic orifice to be. This is completely two separate openings. You can see a normal tissue in between, and that's a biliary orifice. This is a pancreatic orifice in this case. First cannulation was of the pancreatic duct, and then realizing, oh, there's no biliary orifice is at a second, it's a totally separate, then place a stent, and then going to the biliary orifice. And then this is an periampullary diverticulum, or in these cases, as I mentioned, sometimes they are so easy and you just go straight in, and other times they could be quite problematic. So this is one of the examples, even though it's inside, but you can see if I'm just trying to talk to the papilla with my wire, and it does listen, and it goes straight in, no problem whatsoever. And this is one of those examples where it's really, really easy to get in. And then there is another example here. You see, this you can see there is a little bit trauma, so it's not like just all straightforward. So I've been there for a little bit and struggling there, probably. And now, finally, when I get a look at this tip into the orifice and inject to get an idea really which way I have to go, and it was the injection went in and it went a little bit to the left, and that's what I needed to know, where the wire is going to have to take the turn. And this is even worse than the previous one. And here you can see the orifice is somewhere here. I'm trying to just get an idea, move the folds and see where the orifice is. It's not only under the folds, it's at the rim of the diverticulum, and it's on the left wall, and that's usually are quite difficult sometimes. Sometimes they are on the other wall, and they are relatively easier. Here, if I do that, I'm trying to get in. Every time I gently try to talk to it, it is angry, just like your angry friends sometimes, and they just look other way, and then you have to fix them somehow. So in this case, what I'm using is I'm using the clips and then attaching those folds a little bit to the wall on the side, so at least I can have a better face-to-face talk to this papilla. And after that, you can see that the wire tip go. Okay, so there we are back in. So you can see that the wire tip went in. After the wire tip goes in, then I am able to move my tip of the cannula sphincter over that, and it gently moving around, and eventually it gets in. Okay. And here it was really not pushing on it. It's a gentle pressure on that and just trying to move the scope a little bit right and left, and just trying to negotiate with the papilla until it agrees with you. Okay. And this is another example. This is also another mad friend, and doesn't want to go away, but also doesn't want to talk to you. And this is kind of a papilla is really in close to the junction of second and third part of the duodenum, and I can't even get underneath the papilla towards the other end, so to cannulate it. And in this case, really have to use a longer part of the sphincter to at least just engage the tip somehow to the orifice, into the orifice, and then I'm not going to push the sphincter in. I'm going to pull it towards me to really get into a better position, but without losing that engagement of the papilla. And once I have wire in and I know exactly in the right position, then what you do is you go into the lumen, bow it a little bit, and then pull it back towards you. What that does is that brings it to pulls towards you, and you can do a sphincterotomy on those. And these ones you really can cut quite far. And this is another example where I was saying sometimes really you can't do everything wire-guided cannulation. This is a malignant biliary stricture, distal stricture, mainly due to the pancreatic tumor. Here it looks so beautiful, so easy. You are in there, no problem, but the wire doesn't want to go anywhere. So here, when you're gently advancing, you're going to see that it makes a little bit loop. This is good. This is good. Keep it like that. Don't let it go. Eventually, it will get find its way. If you have instead of that, if you really had a tip there only, then you are at risk of creating a false tract. And this one, you can see how the stricture was, and have to really be persistent a little bit to get in there, but without causing a trauma. This is what happens sometimes. You go in there and you cannulate the pancreatic, or you cannulate, you are right in there. Oh, I'm in the pancreas while I wanted to go into the bile duct. You go, come out, you go in, same thing. Come back, you go in, same thing, even though it's very clear orifice in there. So what happened was, in this case, this was a normal, like a septum coming all the way towards you, towards the orifice. And what you did is, instead of going above the septum, first time you went below the septum with the cannula. What that did is that pushed the septum up. It's called the plastering of the septum to the upper wall. So there is no way you're ever going to be able to get in that with a cannula. So you have to realize that when that happens, and then use a wire tip to just stay really close where the ampulla and where the you think the orifice is starting from the top, and stay really close to that, and then just move the septum with the wire tip downwards, and that would take you in eventually. So what happens if standard technique fails? You can place a stent. If you go into the pancreatic duct, you can place a pancreatic stent, or you can use a double wire technique. You can use a curved wire, and you have to really know how to spin these wires really to get into, sometimes to find out your way. So this what the double wire does is, I had a video, I'm sorry, didn't get a time to edit that, so can show you that. It's a 16-minute video. I don't think you are interested in that. But this is a picture, an older picture example of that. So once you get into the pancreas and you put a wire in there, what that wire does is it kind of straightens the papilla for you. So you have a better approach at the papilla. And you will have a better luck with that too. And then you can use a wire tip or cannula to go above that. And other times just put a stent into the PD. But remember that if the papillary orifice is small and you put a stent into the pancreatic duct, sometimes it may make it even difficult for you, and especially if the stent is 5 French or bigger than that. These, I'm not going to talk about these, except one thing. I will show you this video of needle knife. And the only thing is I want to really stress on that, it was I try my best, if I have to do a needle knife, not to do without a pancreatic stent here. You can come from top down, you can go from bottom up, whatever is feasible for you. But you have to go deep enough. You have to, because you cannot just cut the mucosa and then think that you're going to be able to get into the orifice. You have to cut a part of the sphincter, keeping in mind, don't cut the wall either. So it's a very, have to be a very balanced and very, very careful approach. And in this case, you can see the muscle has opened up, and then it's really gonna be very easy to get in there. And that goes nicely, smoothly in there. This is another video, but I will just skip that. The reason I showed that video is if I have to do it, a needle knife, my preferences always have to have a stent in there and then do it. There's a reason for that. One thing is, once you put a stent in the PD, it provides you a direction for the cut, and also helps you limit the depth of a cut enough to expose the sphincter, but not too deep to cut through the wall. And also it helps you stabilize the needle knife. And for any reason, you're able to either you fail to cannulate the duct, bleeding happens, patients having some cardiopulmonary compromise, and you have to stop the ERCPR procedure. At least you have protected the pancreas, and you can always come back at a second time to do that. So this is an example of a PD cannulation. If you have to really trying that. In case of pancreatic really cannulation, usually when you move a small wheel away from you, that gives a better trajectory towards the biliary orifice. But if you move the small wheel towards you, and then it gives you a much better direction towards the pancreatic orifice, and really you have to go straight You don't have to do any curving or anything. It's really just straight into the pancreatic duct. That's what you have to do. Other thing is, a lot of people may tell you, just if you are in the PD, and try not to inject and just go with the wire. Remember that pancreatic or duct, especially if it's without any pancreatic pathology, it's a very delicate duct. It's a delicate side branches. I know contrast is a risk of post-ERCP pancreatitis, but rupturing a side branch with the wire tip is even worse than the contrast itself. So my personal preference is always, if I'm gonna go into the PD, unless I think I'm in the bile duct and my wire just starts keep moving in smoothly, and until I realize that it's taking a turn to the right, and in that case, it's fine without injection. But if I have any trouble, wire starts bending anywhere, and I think I'm in the pancreas, and I want to stay in the pancreas, I almost always inject to get an idea which way the main duct is going, just like in these two cases. And this is an example of putting a stent in that. And you can see here the wire is coming downwards, even though there's no contrast. This is an accessory duct, actually, the minor papilla. Dorsal duct, I should say, dorsal duct, and that's where it's going. So it's fine. So I pull it back and then redirect to the main duct, which goes easily, smoothly. It would have been difficult a little bit to do that unless I had a contrast in there. So pancreatic, this is a pigtail stent. One thing is, when you with the pigtail stents, is like once you get to where the tail starts, you don't use the elevator at that time. Very, very important, because if you use the elevator at that time, it's just going to push the whole stent in there, and with the tail in there. So release the elevator and then gently push it with the pusher. And what that does is that moves the tail downwards, and then you can pull the wire out easily. So that's in regard to that. And I think maybe I'll just quickly go through that. This Bile-Rot 2 anatomy, or altered gastric anatomy, like a gastric bypass. We have used usually a double balloon ERCP to perform ERCP in these patients. There is a cap on in front of that. I don't know how many of you have used the double balloon scope. It is one of the worthless scopes, really, with regard to therapy, and especially if you have to really do some major therapy there. One thing is, its working channel used to be 2.8 millimeters. Thankfully, now it's 3.2 millimeters, so you can get some stuff through that. And this is a patient with a bile leak, and you can see that how it's like doing a ERCP with the EGD scope, where you have much less control over the scope. This is a special scope which is not 200 centimeter long. The only special about this is it's 156 centimeter long. So I'm able to push some accessories through this. But the working channel is now 3.2. It's like a pediatric colonoscope working channel. So it becomes a little challenging with that. And here, I don't know if you paid attention to the sphincterotome or not, its wire is kind of looping around that. So I use a regular sphincterotome, and I kind of flip it to use it for Bile-Rot 2 or in double balloon ERCP. And this one, as some, I think Dr. Saad always says, is bleeding is only another cut away from you. And so here, there's a bile leak patient. On top of that, I run into this trouble with the bleeding. So here now I'm thinking, okay, bleeding, I think I can deal with that. But let me get the stent in, because only 7 French stent is going to go through that. Let me put that in, at least save the whole procedure, what I did it for, for the purpose I did it for, and then I can deal with the bleeding. So I put a stent in there. that goes smoothly. And then thankfully, what I usually say every time I'm in trouble is God is merciful. God is always merciful. And I was just easily able to inject that with epinephrine, and bleeding stopped. And so that's went well, no major issues. Quick view how I do this, how I flip this. This is a regular sphincterotome. Regular sphincterotome, and what I am doing is, you can see that when you bow it, it's bowing just a regular way, the way it is. Then I flip this tip through that metal wire in there, and then pull it through the other end. You can see that. What that does is, it's gonna invert the tip. And instead of going up when you bow, it's going to bow downwards. So that's the direction in Bilwa 2, because the biliary orifice is downwards. That's how you have to cannulate. So what other thing is I'm going to do is I'm going to adjust it before I put that in. So now you see the wire is wrapping around. So when I'm in the bile duct, the cutting wire is going like this. So what I do is I pull it back and keep watching the wire until the wire is down, facing downwards, and that's where I cut it. Okay, so it's gonna be, there is gonna be, sometimes it's and usually it's close towards the tip when it faces downwards, and that's where I cut it. I think this is our study. It's I think we published in 2015. The bottom line of the study was really if the papilla is able to be reached, then the success of cannulation is close to or more than 99%. And also, I can't stress that enough, that when you watch people doing a needle knife, it looks very easy to do that, especially in experts' hands, but it really is easy because they are using it for the proper indication and proper scenario and proper positioning, and it's you have to know when to use it, how to use it. My advice is, don't use it until you have achieved the rate of 90% or at least 80% successful cannulation without any advanced technique. So when you get to that point, then start, and then you can, then you get into the privileged part of using that. So here, this is from Dr. Reddy's paper. You probably already have seen that if you fail selective cannulation with more than 5 attempts or more than 10 minutes, then and if you're in pancreatic duct, then you can put a PD stent and do over that. If that fails, you can do needle knife, do over that. If, however, you are not able to even get into the PD, and it comes to using a needle knife, just think 10 times before you use it, and because this could be one of your relatives, this could be one of your family member in somebody else's hands. If we don't know when to stop, that's a big problem, and that's the hardest thing to learn for us as endoscopists, when we need to stop and either let anybody else take care of it at some other time, or we come back at some other time and take care of that. So this is a paper which showed an increased number of cannulation attempts, and also the same paper showed increased number of, like a longer period of time, more than 10-12 minutes at cannulation increases your rate of post-ERCP pancreatitis exponentially up. So again, I cannot stress that enough. Don't touch the papilla until you are in the best position to touch it. So with that, I would conclude that minimize unintentional movements, unlearn colonoscopy, and relearn ERCP. Study the papilla, talk to it. When you start talking to it, it may not talk to you in the beginning. it eventually starts talking back. And that's when you become friends, and that's how you become successful. Be familiar with different cannulation techniques, and you are your own judge, like what you should do. And try to learn when to stop. And these are really those stages, what we call as stages of competency. This is the most dangerous one, but first and the last, unconsciously incompetent. You watch somebody doing it, you see it, it's very easy to do it, and you start doing it not knowing that you are not trained enough, you are not competent enough to do that. A good student would recognize that. A good teacher help them recognize that and bring them to the this stage. If, however, if somebody is narcissistic, they would not get out of that stage. So once you become consciously incompetent, you know your deficiencies, then you are willing to learn, and then eventually you become consciously competent. Means you have to put a lot of effort, you have to think through it, you have to control yourself, and but you are able to achieve what expert is able to achieve, and then you become unconsciously competent to the point like now you have learned how to ride the bicycle, you keep going. And then this stage comes, and for everybody, nobody lives forever, nobody is going to be same way forever. And that sometimes for us elderly who are becoming towards the end of their career, it's hard to really learn that stage. So it's better those who are at that stage to learn to recognize that and give that torch to somebody else to carry on. So with that, I will stop. I'm sorry, I think I took almost a whole hour, but I hope I was able to convey the message. Thank you.
Thank you, Khalid, for a very nice talk. You were very precise, and
I can't hear you,
I-
Gasa.
can hear me? Can hear me?
Yes, sir, we can hear you, sir.
Okay. Um, well, your talk was excellent. You covered almost each and everything in the cannulation technique and ERCP. I'm sure the participants must have benefited a lot from your talk. There are a few questions. First question that's been put to me through Facebook is that if we are cannulating over the wire and we're cutting the papilla, when do we get the perforation? And why do we get the perforation?
So the perforation is like you look at the sphincter and you cut the fibers. You have to realize that when you keep seeing those circular fibers, and eventually those fibers end, and you look at the folds and how much papilla is into the duodenum, into the duodenal lumen. You can cut that all part which is into the duodenal lumen, but when it meets the duodenal wall, that's where you have to reassess yourself. And that's, if you keep cutting beyond that, that's where the perforation happens. Cut it, take a look at the fibers, circular fibers, you can cut more, and also take a look at how much luminal part is. So when you get close to the wall and you keep cutting, that's where the perforation happens. So you have to be, if you are not sure, it's much easy to stop, cut a little bit, then stop, and you're not sure, stop there and do the balloon dilation or sphincteroplasty. So that is much safer way to do it than having to just keep cutting. And actually, I have started using a lot of sphincteroplasty because of that reason. And that is much, much safer. And if patients are coagulopathic as well, and that also gives you advantage of using sphincteroplasty, decreased risk of bleeding with that. So it's when you get close to the duodenal wall, and if you are still persistent on cutting, that's where the perforation is going to happen.
Good. Dr. Pradhan has asked that during sphincterotomy, how do we know when to stop cutting? I think you have already answered, but just to clarify further, when to stop cutting? When do you
So
see? When do you see that enough is enough? Now I need to stop.
Okay, so just become conscious about it, like cut it a little bit, re-evaluate, see if you still see more circular muscle fibers of the sphincter. And if there are still more and you feel like you're not, and you are not close to the duodenal wall, you still have a fold of papilla up there, you can cut more. But when you don't have any more folds there, and if you look after you do a sphincterotomy, if it opens up, you start seeing the duct, the very distal part of the duct. When you start seeing that, that's the time to stop, because that means you really have cut the whole sphincter. And even though it may look like you have more space, so the thing is just cut a little bit, take a look, cut, take a look, and see where you are.
So that means that step by step. Don't
Step by
try to
step.
make a ripper. Okay, there's a question from Dr. Asif that in living donor liver transplant, due to intubation is always difficult. Any trick, any technique that you use to get into the duodenum?
Mean cannulation or getting into the duodenum?
Getting into the duodenum and then positioning the ampulla, both.
We don't do a living donor, so I cannot really comment on that. And
Well, I'd given the answer that a careful steering of the lumen at the same time with a long scope position, you're able to get into the duodenal lumen in maybe. At times, in difficult cases, we're finding it difficult to get into the duodenal lumen, putting pressure on the stomach, meaning by in the epigastrium, that helps you to get into the duodenum. And then maintaining the position is always just like any other ERCP. With their long scope or short scope, it doesn't really make much difference.
okay. Yeah, other thing is, like, whenever you have a problem or difficulty in getting into the duodenum, putting the patients on the side is always very, very helpful. That way it's easy to give a pressure as well. Just lift them up a little bit, their right shoulder, and just kind of more like a left lateral position. That helps you get into the duodenum. And I would assume, I guess in those cases, majority of the time in the liver donor, you have to stay in long position to get a best position to cannulate, or I really honestly don't have
Just
much
regular,
experience with that.
just a regular position. You don't need to go into a long position. It's rarely ever that you need to go into a long position, but most of the time it is the short position that you're able to get into. Okay, Dr. Mumtaz asked a question that if the distal duct size allows, what should be the maximum size of sphincteroplasty?
Oh, that's a really good question. I think that should be for a separate whole talk, how to do a sphincteroplasty.
Yes,
But
we have a talk.
I'm going to answer that right now. And so what the sphincteroplasty, there are certain basic rules of that. And one of the most important rule is, if you, I know people do a very big sphincteroplasties, but the safest and the most effective way to do a sphincteroplasty is just from the papilla up to 2 centimeter up, and see what the diameter above that is, duct. If the above, like first 2 centimeter looks really, first 2 centimeter or less than that looks really narrow, maybe let's suppose 6 millimeter, but because of obstruction or for some reason, the duct above that is 12 millimeter, you will be fine dilating the duct up to 11 millimeter and even 12 millimeter biliary orifice. Okay, when it becomes a little longer stricture, that's where the problem can happen. But do not go above than the diameter of the bile duct in that area, which is like 2 centimeter above from the orifice itself. So if it's up to 11 or 12 millimeter, I tend to stay maybe a 1 millimeter less to be on safer side. Then going to 13, or I will do 11 or 12. I don't go above the duct diameter in those cases.
Khalid, Dr. Naqvi has asked a question that when will you decide not to cut or do a minimal cut or to do a sphincteroplasty?
Again, excellent question. In those cases, if I take a look at that, and if I'm not sure how much I need to cut, and I have cut some but not sure, is it safe to cut more or not? That would be case scenario one. Second is these coagulopathic patients, platelets low, especially platelets. And or if for any reason I have to do ERCP on patients who have been on anticoagulation, but it's emergent, and I can't cannulate and get in there, and I have to use a needle knife to even put a stent in that. In those cases, I might do it just a little bit cut of the sphincter. Try to would not try to go close to the wall. Just cut it a little bit, and then do a sphincteroplasty. So coagulopathic patients, that would be one where I'm not sure how where the sphincter or what the landmarks are, and these are the two major reasons I would do a sphincteroplasty.
Okay, Khalid, Dr. Salgado has asked that if there's a suspicion of pylori stenosis, and we see a papilla without any bile, the standard technique has failed. How do you approach? How do you cannulate it then?
I thought that was for advanced techniques question.
Okay, we'll
So,
do it next time. But
the way it is, okay. So if you have in those cases, I try to get into one of the ducts. I try to get one duct. If I'm lucky, get into the pancreatic duct, then I will put a wire and then do a double wire technique. If I'm, however, or I put a stent and then do over the stent. If, however, I'm not able to get into any of the ducts, I have to be certain I'm at the papilla. Okay, just don't, you have to be certain you are at the right place. I have seen that needle knives in very wrong places being done or referred, and then they are nowhere close to the papilla. So in those cases, I really would do a needle knife, even freehand. But I cannot stress that enough, that do that only when your cannulation rate has been at least 80, 90%. And if you run into a trouble, you can rescue that. I usually tell my fellow, don't screw up what you can't fix. So you have to be ready for if you had run into a trouble, you have to have a plan for that. If nothing works, the options are you can ask your radiologist friend to put a wire for you, and you can follow that. We sometimes do a US guided as well, but really rarely. I showed you our study cannulation rate when the papilla is achieved 99.4%. And there were 3 failures in that study, and there was one of the, I think 2 cases were not very, very convincing indication. So advanced technique was not done in those cases because it was the indication was kind of suboptimal.
Khalid, although we have not touched the pancreatic sphincterotomy, but there's been a question about the safety and success of transpancreatic sphincterotomy. Although we can do it at a later stage, because we'll be taking up the advanced techniques of doing the cannulation at a later time. If you want, you can answer, or we can leave it to the next time.
So mainly pancreatic sphincterotomy, that's the question?
The transpancreatic sphincterotomy is safety and success.
So it's a safety, it's quite safe. You just have to be in that direction of, because there's that pancreatic portion of the sphincter, you have to be in that direction around 1 to 2 o'clock. That you have to do really very step by step, fibers, look, and then cut a little bit, take a look at the orifice, cut a little bit, take a look at the orifice. And there's going to be time you see the whole duct or lumen. And that's where you stop. And in those cases, if you are doing it you will never do a pancreatic sphincterotomy in a normal pancreas. You're doing it for either a stone or a stricture or something like that. And those cases are really safe to do. You can direct do a sphincteroplasty of the pancreatic sphincter as well. And that is safe too. But just be careful in that when you start seeing the duct, just stop there. And with regard to biliary sphincterotomy, I think I did mention that if you do a full sphincterotomy, there's really hardly any chance of restenosis, but pancreatic orifice does
Yes,
restenose.
it does.
And so at least 10% of those restenose. And once you get into cutting a pancreatic sphincter, then just keep in mind, you may have to go back and redo it at some point.
Well, what's your favorite position in ERCP, prone or lateral?
I just do a prone. Actually, I if somebody has a like abdominal surgery, obviously I'll do on their back. When the patient is on the back, your best position is the patient is laying on the bed like here. Your back should be facing the patient, and you're looking away from the patient, and monitor should be in front of you to the other side, and that's the best position and say a most stable position if you are doing on their back. But my favorite is prone position. I do sometimes left lateral, so and in situs inversus, I do them on the back actually. And I've done, I think 5-6 cases, and it gives a better position and more stability. Other thing before I forget about the stability of the scope is when you put the scope and the traditional teaching is lock the small wheel so you don't fall back. But actually, I never lock the wheels, almost never, I should say, unless it's I get into a position in very unstable position and I have to have some. I need wheels to be locked, but 95 to 97% of the time I don't lock the wheels. What I do is I torque the scope in a way that the wheels are facing towards my chest, and I'm holding the scope like this, like that. Once the wheels are facing to my chest, the scope kind of, end of the scope, the bent part, it hugs around the duodenal sweep, and you don't fall back. And usually when I'm even doing it like a teaching or something, I will be talking and talking, and it's hard sometimes for me to stop talking. But I am just holding my scope like this, and scope stays in position. When the wheel's facing your chest, your scope will be stable. I think I'll stop there. I see Yasab is saying stop now.
I'm not saying so, but actually more number of questions are coming. But since we already 15 minutes over our scheduled time, and now people have to get back to the work or with the family, and I'm really thankful to you for sparing your time on Sunday morning in Florida. And I'm thankful to all the participants for making it convenient to come here on the forum and participate actively. There's been huge number of questions today, and I'm thankful that you have answered them very patiently and very competently. I'm thankful to the Wilson Pharmaceutical as well for providing us the platform.